Dr. Michael Fine is a writer, a community organizer, a family physician, and a public health provocateur. He is currently Chief Health Strategist to Mayor James Diossa and the City of Central Falls, Rhode Island, and Senior Clinical and Population Health Services Officer of Blackstone Valley Community Healthcare Incorporated, which together opened the first neighborhood health station in the United States back in February of 2019. Dr. Fine served in the cabinet of Governor Lincoln Chafee as director of the Rhode Island Department of Health from February 2011 until March of 2015, overseeing a broad range of public health programs and services. He is also a member of Temple Emanu-El and is yet another example of how individuals with the initials MF are good looking and provide wisdom, kindness, and sage advice. We look forward to learning from Dr. Fine this evening. If you have any questions or comments, feel free to put them in the chat box and I will moderate them so people will have the opportunity to ask the good doctor directly. With that, I will go ahead and put the spotlight on your video so that everyone should be able to see you, and off you go. It seems like only a little bit over a month ago we had a chance we closed the physical space of Temple Emanu-El and moved everything online. And you were so helpful in helping us figure out what to do and how to do it. And we look forward to learning from you tonight as well. So the floor is yours.
I'm surprised you were willing to forgive me. It's nice to be with you all again, to say the least. I think we are probably 2 or 3 weeks since we last talked. I kind of have lost track of time. We are certainly more advanced in this disease. We've certainly seen more of it in New York and in Boston and around the world, and are seeing more of it in Rhode Island. We are about 2.5 million tested cases around the world. I don't have my numbers in front of me, but I think very close to 800,000 in the United States. These are tested cases, remembering that the number of actual cases is probably many times the number of tested cases. In Rhode Island, we have now about 5,500 tested positive cases. We've been averaging 300 to 400 new cases positive a day. We've had 171 total fatalities. We're averaging 15 to 20 fatalities a day. And miraculously, our hospital capacity is holding at the moment. It looks like, as I look at the numbers, that we are slowly approaching what's called the surge, or a very lowered surge, but we're slowly approaching the sort of maximum that we're going to see at this level of social distancing. And it looks like that's going to happen probably 2 to 3 weeks from now. That higher level will be a plateau, I believe, that will last 2, 3, or 4 weeks. And then we'll slowly come down again and probably take another 4 to 6 weeks to come down. I don't know what the summer is going to be like. I think many people are concerned that there will be another surge in the fall when schools open. We keep learning things about this virus that we didn't know, but we don't know anywhere near enough. In many ways, we are flying blind because we just don't have the data that we need to manage or predict intelligently. It continues to be a virus that has no treatment and no vaccine. And the basic, what we basically know about how many people get sick has stayed about the same. Excuse me, roughly somewhere between 25 and 50% of us have it with no symptoms at all. But we've learned that people without symptoms can transmit the disease. 40% of us who get the virus will get a mild condition, coughs and fevers, and muscle aches, and loss of smell and taste, and some GI stuff. but that at a level we can handle. And about 10% of us will need the hospital. A third to a quarter of those will need the intensive care unit. And about half of the people who need the intensive care unit, unfortunately, will probably not survive. So we still think that what's called the case fatality rate on a population, from a population perspective, when all the numbers are known, are probably going to be between 0.6 and 1%. But even so, that's 6 times the case fatality rate, 6 to 10 times the case fatality rate of seasonal flu. We continue to be dogged by the lack of a really good test. The test we have is useful if it's positive, but it's not that useful if it's negative, as about 30% of people with negative tests will have the disease anyway. And that depends on which kind of test you get. The test that you get at what are called swabbing sites, the National Guard sites, coastal, I believe, and a couple of other places where there's a medical process involved, and they use a deep swabbing method. That's probably gives us what's a sensitivity rate of about 70%. That means that there's still 30% false negatives. But the site at Twin Rivers, which is much easier to use, you can drive up there. You have to get an appointment first, but then they give you a couple of swabs to put in your own nose. Each of those swabs has a false negative rate of close to 50%. They give you 2, and by doing 2, you reduce the false negative rate to 30%. But what it really means, our real problem, is we have no way to know if somebody doesn't have symptoms, but still has the disease. We do not have what I call a gold standard test for asymptomatic disease. And that will dog what we do until we get that test, because there will be people who carry it and can transmit it, but who we can't recognize. And that's probably how much of this disease is getting into nursing homes. It looks, one of the things we've learned since we've spoke is that this is a disease that has, that is aerosolized, that is not just riding on respiratory droplets, but goes into the air in the environment around someone who's sick, and stays in the air a number of hours. And anyone who comes into that room after them, even a couple of hours later, can still get the disease. So that's our situation. We expect to see disease in Rhode Island circulating, as I said, for 4 to 6 weeks at least, probably more 10 to 12. I don't think we will be on a downslope till June at the earliest. And I don't expect schools to reopen this school year unless we do something unusual in the summer. And we are learning as we go. So why don't I pause now and take questions?
Well, that's all great news. Thank you for.
Well, wish I had. And the good news is I haven't figured out yet.
Okay,
so good news is eventually there will be a vaccine, or eventually enough of us, 60 to 70% of us, will get the virus, get immune, and then we will get what's called herd immunity, and then the virus won't spread further once we achieve herd immunity.
What percentage of the community do you think in Rhode Island specifically, or in this area, do you think is already infected or already has been exposed?
We don't have a clue. And that's part of the problem with any prediction. In order to understand that, we would need antibody testing, which is what I call serology. And we would need to do it over a large portion of the population, not the whole population, but population samples of a couple of hundred. Those tests are beginning to circulate, but they are from many different producers. They are not yet FDA formally approved. And we don't yet know what the good one is, what the bad one is, and what will become the one that we find, or the number of tests that we find reliable to put into wide use. And until we get a reliable antibody test about which there is consensus, I don't believe that we will be able to answer that question.
So I'm looking at some of the comments, and as a reminder, if you want to submit a comment, feel free to put it in the chat, and I'll funnel it to Dr. Fine. A couple of questions. Number one, people have been putting off certain like life-changing decisions. They've been sort of waiting to move, waiting to either purchase a home, waiting to make sort of changes and figure they could hunker down for a month. But now they need to start doing things like either moving to a new apartment or moving to a new house. Do you have any suggestions or tips for how to make that decision or how to make it a safer choice?
Boy, I think that's a real challenge. I mean, I think I don't know how to predict when it becomes easier. Clearly, there are precautions that we're all learning that make transmission less likely, but I think those precautions are going to be in place for a year. So, if you've got a life change decision that can wait a year, I might. But if not, live your life and take the precautions you need to be safe. Remember, there is most of us who get this will do fine. It's people, I'm sorry. I think that's a function to a certain extent. Those decisions and when to do them may be a function of age and underlying medical condition. So if you're 32 and basically healthy, that puts you in a very different risk group than if you're 88 and have diabetes, heart disease, chronic renal failure, and so forth. Go ahead.
No, you go ahead. Finish that. Sorry.
If you're in the latter group, you want to be much more careful. If you're in the former group, I think it's reasonable to plan over the summer to proceed with life, taking reasonable precautions.
Okay. Thank you. In terms of antibody testing, and do we know anything if you can get it twice? If once you have it and you had it and you're fine, what is the likelihood that you can get it again or be asymptomatic and the next time you will show symptoms?
This is one of the most frustrating questions that I ever have to answer, not because there's anything wrong with the question, but because we don't really have much data. Let me say this about that, however. We don't really have a disease model of a disease that you can get twice. For most of us, we get a disease, we get immunity. If we don't have immunity, we never recover. So we know that we get immunity, we recover, and that immunity usually lasts a couple of years and is maintained by exposure to that organism in the environment. With diseases that we've basically eliminated, we will often see immunity wane over 5 to 10 years. And so we've actually begun revaccinating people against diseases that have been virtually eliminated because their immunity isn't maintained. But I don't know of a disease where, you can get it again, so to speak. Now, there's some question about the whole category, the whole class of coronaviruses, for which immunity doesn't seem to be as deeply seated. But I think that may be because they don't cause severe disease. It's my belief, not yet proven by evidence, that when you get a severe disease that makes you sick enough to have a fever and a cough, or worse, and you recover from that disease, I think you are likely to get an immunity that is pretty sticky. I think the problem will be among people who get asymptomatic disease, or what's called asymptomatic carriage, where you don't get a deep-seated infection, and so your body doesn't have the challenge needed to mount an immune defense. But again, all this is speculation at the moment. Remember that we believe this disease crossed over to humans about November 17th of 2019. It got a name on December 30th of 2019. So this is an entirely new disease, not only to our immune systems, but also to our science. And it's going to take a year or two before we get enough data to have reasonable answers to these intelligent questions.
When we last spoke, you had advocated that we all start making masks and have them at home to help us self-quarantine, and you were suggesting that each person in the house should have 7 masks. What are you suggesting now? Should we be wearing them when we go out in public, when we are in our cars? How often should we be wearing masks, if we should be wearing them at all?
Well, first of all, I think you should wear masks anytime you go outside right now, particularly anytime you go to a store or anything else. But I think pretty much anytime you go out, you should wear a mask. That's becoming the standard. It's actually just become the law in Central Falls, and I think Barrington, and East Providence. And I think that law is likely to spread. You know, I don't think they're really necessary in cars if you're in a car by yourself. But all the rest of the time outside, I'd wear a mask. And I think they're actually important inside, in the comfort of your own home, if you get sick or if anyone in your house is sick. Again, there's no science that proves that. But I think that may be correct, mostly because masks provide an opportunity to reduce the spread of virus by respiratory spread. And anything we can do to reduce that spread and reduce the amount of virus that leaves the body, I think is better for the community as a whole. I think I saw a question go by that said, even on a walk or on a bike ride. And I think for the moment, there's nothing wrong with doing it on a walk or a bike ride. I think, right at this point, as the disease is much more common in Rhode Island, and we have aerosolized spread, if you're the only person on a desert island, I would say not necessary. But now, there's no downside in doing it other than that, they're uncomfortable and, they make my glasses steam up. But, this is a good time for overcaution as a virtue.
Can I ask what you do personally? Do you wear a mask when you go out, or gloves when you go to the supermarket, or how has this impacted your personal practice?
I wear a mask when I go outside of my personal property. I'm sometimes outside, some of you may know I live in the country on a fair amount of acreage, and work to bring in wood. When I'm doing that, I don't wear a mask because there's no one within, usually half a mile of me. Mm-hmm. But outside of that, I wear a mask every other time I go out. And I do wear gloves in the supermarket. I wear work gloves, but, I wear gloves in the supermarket. It's kind of dumb, but, it feels dumb. It feels clunky, but there's really no downside to doing it.
Like you use like gardening gloves?
Yeah, like gardening gloves.
And then you wash them when you get home, or?
Yeah, I stand them in a corner and just let them sit for a couple of days.
Oh, that's a good alternative if you can't find the disposable gloves.
Yeah, and I find them around, and I don't want to waste disposable gloves that may be needed at some point by healthcare workers.
Someone has a specific question. If someone gets COVID who had the Prevnar, do we know if they are less likely to get pneumonia?
I don't know, but I doubt it. because the pneumonia caused by COVID is a viral pneumonia, and Prevnar prevents a bacterial pneumonia. Um, Obviously, if you get the viral pneumonia, you can get, maybe not obviously, you can get the bacterial pneumonia on top of that, and that's a very severe problem. And so the Prevnar probably prevents those two together, but it doesn't prevent the viral pneumonia. And it's the viral pneumonia that appears to be most severe, and that's what's causing much of the sickness and death.
Can you, do you have any suggestions for how to talk to children or teenagers about seeing everyone in masks or seeing everybody wearing masks? How would you talk to kids or young parents about why everyone's wearing a mask?
Well, I think it's, I'm always a proponent of telling kids the truth because they figure it out anyway. So my sense is, you know, we're at a time when there's a disease spreading around. We know it won't be here forever, but everybody's wearing masks to protect themselves, but mostly to protect other people. And that's a good thing. That means everyone wearing a mask is somebody who cares about you and the community in which they live.
That's beautiful.
I'd
I
probably
love
leave
that.
it at that and take questions. And the answer to the question, will we always have to? Is probably not, but we have to for right now.
Thank you. When you imagine or when you see in the news that these movements of trying to shut down or trying to end these stay-at-home requests or quarantines, how do you, first of all, what do you think about these decisions of different governors that are opening up or trying to open the economy, so to speak? What are your thoughts on that?
Well, I'm looking only closely at Rhode Island and know its epidemiology best. So one can imagine a world in which the disease really isn't circulating, a world in which they got ahead of it and made sure they had enough testing and enough uh, intensive care units and enough hospital beds in case it started to build, and a world in which everybody who was symptomatic knew that it was time to get in isolation and that their departments of health could identify everyone symptomatic and identify all their contacts, which is kind of what they did in South Korea to contain it. If I had a state that looked like South Korea in terms of infrastructure, I think that's reasonable. South Koreans have been able to manage this disease, as have the people in New Zealand, without, in New Zealand, they shut the place down. South Korea, they were able to do it without complete social distancing. But that's because they were in front of it. And if your state is that state, then that sounds fine. If your state has documented community transmission of disease and doesn't have great testing and doesn't have a great infrastructure, I'm used to saying that this virus is a fierce taskmaster. And if you open too early, you will get the disease spreading and you will be closed down, not by the government, but by the disease itself.
Hmm. What do you imagine? I know it's hard to decide. What decisions would you use to decide which organizations or which businesses would be able to get open first? How would you decide?
Well, I wouldn't think about opening until we have rapidly declining cases and probably no new cases for a period of time, probably 10 to 14 days. With good surveillance, with a good sense that we're going to hear about people who are sick when they're sick. That's the first condition as far as I'm concerned. If I had widespread antibody testing that showed we were 60 to 70% immune, then I'd be much more comfortable about opening. But regardless, if we had evidence that the disease was under control, then I would probably open situations where you didn't have large numbers of people in a room together, at least until we had a good test for asymptomatic disease. This is assuming we don't yet have a good test for asymptomatic disease. So I mean, in that world, golf courses seem okay. And, opening public parks, as long as people don't congregate, seem okay. But rock and roll concerts and frankly, bringing people together in a synagogue would make me a little short of breath.
Like hypothetically, I was going to ask synagogues. When might synagogues we would be able to gather for Shabbat morning? It sounds like this is something that's a little still far off in the horizon.
I think a little far off in the horizon. Now, if the disease had really gotten quiet and everybody wore a mask and was willing to sit 6 or 8 feet apart, I could see us opening again. But I think it would require those disciplines.
Nobody sits in the first 10 rows. So, I mean, this is a challenge I face every Shabbat. So
yeah, right. It's no different, except, we probably want some people to sit in the first 10 rows because we only want people in every other row.
Right. All right, let me look at another question. When people start moving about and doing businesses, when people start moving about and they're running their errands, how often do you have to change your gloves? Should you be just poking things with a stick or a cell phone? How worried should you be about touching buttons as you go around running your errands?
Well, I think you want to do it as little as you can. The science here is not that good. You got to live your life and you want to be reasonably careful. So I would touch stuff that's publicly touched as little as possible. And the moment I'd get home, I'd wash my hands. And I would do some thinking about changing my clothes as I came into the house, particularly if I live in a more densely populated place, like Providence or Pawtucket or Central Falls or Cranston.
Just as a reminder, everyone, if you have questions, you can, if you have any questions, you can put them in the chat room, or even on Facebook, you can put them in the chat room there as well. A couple of people have asked about summer camp again. If you could just reiterate what you think might happen with regards to summer camp.
I think not this year, unfortunately. I don't see how we're going to be able to make decisions in enough time to get summer camps open. Now, maybe, we could decide, maybe we would find on June 10th that we've had no new cases for a week. And people can still get if people could still get camps opened, then, it might be a reasonable thing with lots of oversight and surveillance. But just when I think of kids sleeping in bunks, I think it's going to be a tough call this year, unfortunately.
Is there anything that the CDC is recommending that you think isn't necessary, or things you wish that would become part of our standard operating procedure for how we move about for the next month?
No, I think the CDC recommendations are reasonable in general. I think they were slow to recommend cloth face masks, but they've come around to that because there's no downside in doing it. I can't think of anything new people should be doing. So I think the CDC is in a reasonable place at the moment. I just wish, like nothing else, that we would get a test for people who carry the virus asymptomatically. Because I think when that happens, that's going to be a major breakthrough in how we manage this condition.
When this was back in February and early March, when you started sort of sounding the alarm of saying we need to take action, did you anticipate that we would be flattening the curve for as long as we've been doing it? I think some of us might have thought, it'll take a week or two to do it and we'll be done with this. But clearly we're already a month in and there's still more time to go. Is this what you had thought how long it was going to take?
Well, I actually think we've done better and had greater success than I anticipated. And I actually think that time will tell, but I think there may be a unanticipated positive consequence of what we've done. And that is, I suspect that we will have fewer deaths among young people as a result of this. And that's a good thing. But, I think I did not think that we would be this successful. And I guess I didn't think through in much detail the consequences of that success, which are fewer people ill, fewer deaths, perhaps, um, and a much longer period of having to be at home. Because, this is this trade-off. If we didn't do social distancing and it all happened at once, we'd be done by now,
Right.
except we'd have awful consequences. We would have had much greater pain in terms of loss and illness and death than we have now. We would look more like New York and New Jersey.
Can you talk about capacity here in Rhode Island? I know we had talked about setting up large scale like field hospitals, and so we can augment our capacity. Where are we in that? Number of ventilators, things like that.
I don't know about number of ventilators. I think I don't know myself. If I'm reading between the lines, I think we basically may have doubled our capacity and may have 400 to 500, but nobody's told me that straight up. Our classic capacity was about 180, and I suspect that we have twice. I think I knew that we had 200 in reserve, so my guess is that we're in the 400 to 500 range, and at the moment have 44 occupied by people with COVID. Hospital capacity, they've built a field hospital or two, I think it's two, and I think we have an extra 1,000 beds of a baseline about 3,000 bed capacity. And at the moment, about 275 beds are occupied by people with COVID. So 271 beds to be precise. Or that's what was the case at 1 o'clock this afternoon. That changes every few hours, of course. But we're in a good place. And I can't predict how high these numbers will go. But I study the rate of rise because I think the rate of rise is the most significant number. And when I look at our rate of rise, it's been pretty flat for a number of weeks, which means I don't think we're going to go way high in our number of hospitalizations and ICUs. I mean, it wouldn't shock me if we double, but I don't think we're going to triple or quadruple. I may live to eat those words, but I think we are doing astoundingly well. Way better than I ever thought we'd do.
And the we, to be clear, is our communities here in Rhode Island and in the immediately surrounding areas.
Yeah. I'm talking about just Rhode Island. And obviously, New York suffered, and New Jersey suffered, and is still suffering. But I don't think we're going to be in that place as if I'm reading these numbers right.
And to be clear, this is not, you're not suggesting, and so therefore we can sort of let go of the throttle. In fact, this just means that what we're doing is making a huge difference, and we need to continue making a huge difference for a while.
Yeah, no, this is in its own way a biblical disease. That is to say, if you don't do what the disease is telling you to do, you will be punished.
Right.
It's the moment, if we ease up on the throttle too early, we'll get a spike. And I'm still considerably worried about our more densely populated communities, Providence, Pawtucket, and Central Falls. I haven't looked at the Woonsocket numbers recently, but Woonsocket is also a place that's densely populated, because I have very good evidence about what's happening in Central Falls, and that is a hot spot. And may peak earlier and may peak higher, just because of the density of population and the fact that poor and working people have to go to work every day.
Right.
And so what's happening in our more densely populated places is that people are much more likely to have to leave their homes to go out to work. And when they leave their homes, they contract the disease usually from other people at work. They come home to a crowded apartment of 6, 8, or 10 people, and then pass the disease to everyone at home. And we're hearing lots of those stories in Central Falls, where I'm most connected. And in many ways, this is a particularly painful disease because it sort of is punishing us collectively, though the punishment is wreaked on the poor, but it's punishing us all for allowing people to live in crowded circumstances, allowing people to have to work for low-paid jobs where they have to go out to work. The stratification of the society that we've allowed is going to be the source of much of the illness and death. And it's something that I'm ashamed of every day.
How can we then work to try to change that in terms of what can we do, obviously politically speaking, but also what can we do to support those who are providing the care in our community?
Well, I think it's not forget and work to change this. I think of Isaiah a fair bit and his definition of, what is a righteous fast. And so as much as I appreciate everyone applauding healthcare workers and giving healthcare workers food and, calling people heroes, and they are, I think most of my colleagues who are healthcare workers really on the front line, which I am not, would just as soon have us house people and make sure everyone is housed and make sure everyone is fed and make sure no one's going hungry so that we don't get in this situation again.
I think a lot of the things you're advocating for were just the things that Isaiah was arguing for so many thousands of years ago, of taking care of people preventatively so they don't become victims or don't become sick or in need later on.
And not because you're afraid of punishment, but because it's the right thing to do.
Agreed. A couple more questions. Can you talk about public transportation or for people who need to commute into Boston or use buses or trains here in the area? Any tips or suggestions on how to mitigate dangers?
Not specifically, same rules apply, 6 feet apart, 8 feet or 10 feet if you can get them. Wear a mask if you can, wear gloves if you can, and wash your hands as soon as you can. No magic here, just the same basic rules apply.
I think the idea of changing your clothes as soon as you get home is something significant that people can try to do, but they might not have thought of ahead of time. Once kids go back to school and once we all go back to work, is it inevitable there will be another spike?
Inevitable is always a dangerous
Fine,
word.
so, likely or within the realm of possible.
I think as I'm reading the numbers and sort of reading between the lines of what people in public life are saying, I think most people are expecting it. And it's because all diseases are passed in schools. It just is the way infectious disease works. Influenza is passed by 6-year-olds who bring it home to their grandparents, and when their grandparents get sick, those are the people who end up getting very sick and sometimes passing away from influenza, not the 6-year-olds that got it. But, that's what we have to look at. Now, the one thing I hold out huge hope for is that we are having, though I have no proof of this, and I don't have any reason to think it's actually happening, but I hope that there is a huge transmission of disease that's occurring asymptomatically and occurring in a way that triggers immunity, so that we're going to wake up one morning and find that we are at 65 or 68% immune without a zillion people sick. That would be, the most amazing outcome. And if that happened, we'd be in a wonderful place, but I can't promise that by any means.
I know there's lots of work being done on testing. When do you hope to have a test? Do you think that seems pretty, has a high rate of detection?
I can't predict that at all. I think that is technologically difficult because of the behavior of the virus. And I don't want to bore people with the technology of it, but I think that's a ways off, 6 months or a year. And I'm hoping there are colleagues in laboratory medicine who are doing everything they can to figure out the technologic needs of getting that done. I think if anything, it will be a urine test, surprisingly. But at the moment, we're having trouble detecting this virus in the urine. So we got a long ways to go to figure out that technology.
I guess I think if anyone has any questions, please you can put it in the chat box, or you can put it on the Facebook chat room, and we'll take a look at those. As I'm sure you've noticed here, or at least many of us have noticed, the weather is getting warmer. People are spending a lot more time outside. If you were to, recognizing that people want to get outside and go and do things, how would you suggest they gather? Are we talking about in people's lawns, sitting on their chairs in the backyard, masks? What would you advocate for?
Well, I think, if you're going to be with people, it's with masks and, far enough away that you're not quite that close. I mean, the problem is we don't know who has this disease and doesn't have a symptom, but can still transmit it. That's our problem.
Yeah. Are you suggesting, I know Rhode Island just opened up 2 testing facilities. Can you talk about how you get a test? Is it worth people getting tests? How reliable are they?
It's only worth getting a test if you have symptoms, because the test is way less accurate for people who are not symptomatic. Being symptomatic perversely gives you the best test. And then the way to get a test, there are 2 current methodologies. One is if you have symptoms to call your primary care, your family doctor, your primary care doctor, and that person will take you through about a bunch of questions over the phone. And if they think it's appropriate and you have the symptoms that might be explained by the test, they will order it for you from a lab. And then I don't know, my guess is they send you the order electronically, and then they help you schedule the test, usually at one of the bigger testing sites. And you go by schedule. The other opportunity is to go online and go onto the website of CVS, key in your symptoms, and if you have the right constellation of symptoms, they will schedule a test. You drive up to Twin River in Lincoln and get the test in that parking lot. And for that one, they give you the result right there. The good news is you get the result right away. The bad news is, at least according to the literature, it appears that that's a less accurate test.
There are, many of us have relatives in nursing homes or in rehab facilities. What would you suggest we tell our relatives who are in that situation to be extra careful or to be cautious?
To be as careful as they can. Nursing homes are particularly difficult, as everyone knows. I don't think it's in the control of people in nursing homes very much at all. So, I think live your life, enjoy your life, and hope you don't get the disease. Wash your hands a lot. And I don't know for sure whether people in nursing homes, whether patients are masking or not, but if that opportunity is provided to you, by all means take it. The state is doing lots of work with nursing homes to try to make them safer, to try to make it less likely that staff brings in somebody who's got an asymptomatic infection and which can't be detected, brings it in. The state's about to begin a regular testing process where everyone in nursing homes will be tested routinely, I think once a week or once in 10 days. And certainly that can't hurt, but it doesn't get us around the problem of asymptomatic carriage of disease.
And so, and I guess my final question for this evening, in terms of, penultimate question, in terms of masks versus scarves versus do-it-yourself at home versus any of these things, do you prefer one over the other? Is it meant that you wear it once and you should wash it or throw it away? Or what's your practice regarding masks? Masks or scarves?
Cloth masks that, I cut the fabric, my wife sews, and we make masks. It's our evening avocation. And that is perfectly fine for someone who's not a healthcare worker. I think the consensus is to try to save surgical masks for people who are healthcare workers or in healthcare settings. I can't tell you about how masks compare to scarves wrapped around your faces or bandanas. My guess is the rough sense is that the harder it is to breathe through, the better it is.
within limit, right? Within limit.
Within limits, right? You got to breathe every single day, a couple times.
You're painting a picture of you, Michael. I'm seeing you chopping wood outside your house, sewing masks and cutting cloth. It's a very rugged look that I'm imagining you after we hang up this call. I guess my final question is, if you want...
I'm a Jewish guy from the Bronx. How rugged could I be?
My final question is, what do you want people to walk away with from tonight's conversation? What would be one or two specific action points that you would want people to be mindful of?
It is to keep doing what you're doing in terms of social distancing. Don't cut corners. And even more important, understand what you should do when you get the first symptom of something. Don't do what I've always done, which is say, maybe not. I'll see what I'm like, see what it's like tomorrow. And then tomorrow say, not sure yet. Let's see another day or two if I get a fever or if I get short of breath. Don't do that. The moment that you get a symptom, go into a room, put on a mask, call your doctor, and then do what you need to do. But the moment you get a symptom, plan on being in a room by yourself for 7 days, at least. Don't cut corners on this one. Play it straight. That way you protect everyone else. And that way, I think you're more likely to get better faster.
I think what you're describing is that we all have a role to play in helping not only keep ourselves safe, but also keep our friends and our families and the greater community safe as well. And what we're being asked to do is to put on scarves or masks, to try not to touch so many things when we go out in public. And when we need to run errands, to be safe and thoughtful in how we do it, to reach out to other people in the community to see if they need help and how we can help those who are in need or perhaps in at-risk populations. And together we will eventually, hopefully, start seeing numbers go down and eventually think about being able to reconnect face-to-face without a mask sometime, hopefully, in the not too distant future.
Perfect. Exactly.